So let's conclude our thoracic imaging with part 4, which is going to look at pathology involving the mediastinum and the vascular structures of the thorax. We're going to take a minute to review cross-sectional anatomy of the mediastinum, and then we'll move into pathology affecting the aorta, pulmonary arteries, and the heart. We'll also look at some common abnormalities affecting the mediastinal structures. So here we have 3 CT images of the chest. Here we're just below the level of the thoracic inlet. We see the upper trachea. As we follow the airway down, we can see we're at the level of the carina with branching of the right and the left main stem bronchus. Here, just slightly distal, extending into the hilum. The esophagus here to the left lateral aspect of the trachea, small amount of gas. We can see the normal positioning of the esophagus posterior to the trachea here at the level of the carina, and here within the posterior mediastinum with just a trace amount of fluid contained within the lumen. The thoracic aorta, which we're depicting here on 4 cross-sectional imaging images of the chest. Here we're at the level of the great vessels. So we have the right brachiocephalic artery, we have the left common carotid and the left subclavian artery. Here we have the ascending aorta, the proximal descending aorta. We're at the level of the aortic arch, and then we go into the descending thoracic aorta. Here we're at the aortic root near the level of the aortic valve. Pulmonary artery, nicely opacified pulmonary artery. We can see the relationship to the ascending aorta. It is just to the left lateral aspect. Well opacified vessel. As you can imagine, I'm going to show you an example of a pulmonary embolus, but really rely on contrast opacification of the pulmonary arteries to be able to detect filling defects and clot within that artery. Here's a nice example of a repaired transposition of the great vessels. You can see that the pulmonary artery appears draped over the ascending aorta, and this is a normal appearance of a patient who's undergone transposition repair. So as I promised, filling defect within the left pulmonary artery. This is a pulmonary embolus. You can imagine if this was not well opacified with contrast and it was similar attenuation to soft tissue, it would be very hard to detect a filling defect, that thrombus within the pulmonary artery. So just a review of the cardiac chambers. Here's the right atrium, the right ventricle, the left atrium, pulmonary veins extending into the left atrium, and then here we have the left ventricle. The left ventricle is the more posteriorly positioned ventricle, and it's also easy to identify because the myocardium is thicker. So moving on to cases, here's a 60-year-old male with chest and back pain. So this is an example of an acute aortic dissection. This happens to be a type A with involvement of the ascending aorta. So in an aortic dissection, you develop an intimal flap, and you get this double lumened appearance of the aorta. Here's a nice cartoon depiction of blood flow extending through the ascending and descending aorta. There's a defect that occurs where blood can then dissect out and create that false lumen. Here's an example of a small focal dissection flap or an intimal flap within the descending thoracic aorta. Here it kind of looks like a focal dissection. Here, the way that we're covering it on these coronal images, it looks like just a small little focal flap, but nonetheless, example of acute aortic syndrome. 35-year-old female with hemoptysis and chest pain. So we can see CTA images with opacification of the pulmonary arteries. Here's the ascending aorta, which is not opacified. We have large bilateral central filling defects within the pulmonary arteries. So these are the pulmonary emboli. And then we have this opacity as well as a small pleural effusion within the right lung. So given that the extensiveness of the pulmonary emboli, this is almost certainly pulmonary infarct. 89-year-old female for annual exam. We have a frontal and a lateral view of the chest. So nice example, we have an opacity here on the frontal view with a small air fluid level. On cross-sectional imaging, this corresponds to a hiatal hernia. 34-year-old male with night sweats and fatigue. So contrasted exam, we see the ascending aorta, the descending thoracic aorta, and the main pulmonary artery. We have abnormal soft tissue density within the mediastinum, mainly middle, but also extending into the anterior mediastinum. This is lymphadenopathy. And in this patient, this was confirmed to be lymphoma. We also have small dependent layering pleural effusions. 40-year-old African American female with cough. So this is an example of sarcoid. We can see that there is bilateral hilar adenopathy. We can also see that there's thickening along the right paratracheal stripe corresponding to enlarged lymph nodes. Sarcoid is a systemic disorder which creates non-caseating granulomas. Multiple organ systems can be involved, but most commonly the lungs and mediastinum are affected. The classic imaging appearance is bilateral symmetric mediastinal and hilar lymphadenopathy. Can also have perilymphatic nodules, pulmonary consolidation, and even can result in end-stage pulmonary fibrosis. Here's an 86-year-old male presenting with shortness of breath. We have a comparison radiograph 4 days prior to the recent study. We can see that he has a right ventricular ICD lead in place. And if you notice, there was enlargement of the cardiac silhouette within a relatively short period of time. Here we see a non-contrast CT chest performed 1 year prior, and there's no fluid surrounding the heart. On the recent CT, which was performed with contrast, we see this fluid attenuation circumferentially surrounding the heart, and this is a pericardial effusion. So like the pleural space, the pericardial space is a defined space created by visceral and parietal pericardium in this instance. Normally there's a small amount of fluid within the pericardial space, 30 to 50 milliliters. On chest x-ray, you may see serial enlargement of the cardiac silhouette, suggesting that there's accumulation of pericardial fluid, and it's much more clearly defined here on CT where we see fluid circumferentially surrounding the heart. And that concludes the cases that I have in the thoracic imaging. I'm just going to take a quick minute to just briefly go through our learning objectives one more time and remind you of the things that we have discussed. So we looked at lines and tubes, and then we reviewed pathology involving the lungs, pleura, and the mediastinum. So in the lungs, we looked at chronic lung diseases, emphysema, including centrilobular and paraseptal emphysema, as well as pulmonary fibrosis, where we have thickening of the interstitium and associated findings like architectural distortion, honeycombing, and traction bronchiectasis. We looked at pneumonias. We saw an example of both atypical as well as bacterial pneumonia. We reviewed pulmonary edema, both interstitial and alveolar opacities, and we looked at an example of pulmonary hemorrhage as well as atelectasis. We looked at a case of primary lung cancer and a left upper lobe collapse. And we also looked at 2 examples of pulmonary metastasis with bilateral pulmonary nodules and masses. We reviewed pleural anatomy. We saw examples of pleural effusion. We saw hemothorax as well as pleural hematoma and empyema and pneumothorax. We looked at imaging involving the mediastinum. We saw an example of an aortic dissection, traumatic aortic injury, as well as pulmonary embolus. And then we reviewed abnormalities involving the mediastinum, including hiatal hernia, lymphadenopathy, and pericardial effusion. I hope you enjoyed the lecture. Please feel free to email me with any questions or comments. I'd love to hear from you. Thank you so much.